I'd support a landscape of less regulation, less licensure, because I think folks understanding that there's not some stamp that says, hey, this person is quality, folks are going to create their own understanding of who is quality and who's not quality.
This is an employer-driven bill, if you really think about it, right? Someone who is having a hard time finding physicians to staff their hospitals.
How are we going to underwrite that risk? This is why insurance business, we call it risk transfer. Like, who are we going to transfer the risk of them screwing up? Because we know it's going to happen, right? Because we don't know where they came from. We don't know who they are.
40% of the NHS, 40% of the house staff, junior and senior house staff in the UK is international medical graduates.
Oh, yeah. Look at that. Welcome to the Doctor's Lounge. My co-hosts tonight are Dr. Anthony DeGiorgio, Dr. Dan Choi, and Dr. Sennett Dixit. Yeah, see? Look at that. Oh, and he decided to show up. The other co-host tonight is Dr. Anish Koka with his amazing tie.
Interview.
I believe you. But right now, we have an exciting show to talk about. We're going to cover the debacle in North Carolina, Dr. Koka's favorite topic, Vinay's return, and Medicare's cuts to professional fees and what it means to independent practices. But before we begin, a quick update for all of you tuning in to the Doctor's Lounge. I love this. Over the last 30 days, we had 1,400 downloads. But the real story is this: 1,200 downloads just in the last 7 days. So I think the physician community is hungry for some straight talk about policy and politics and how it results and affects independent practice. Thank you guys all for being a part of it. And look, you can subscribe to our podcast on Apple, Spotify, and wherever podcasts can be found. Man, that's cool. I know I kept sending you guys this stuff all weekend, but that's because I was so stoked. I was like, what the heck is going on? Our podcast is on fire. People are listening. And then I'm getting text messages from other doctors around the country. A couple of my buddies in Utah, a couple of buddies in Texas, and then a guy in Missouri. We're all like, man, this is really good. So congratulations to you guys. You guys make it happen. I just sit here on the camera and ta.
That's the hardest part.
Yes. Okay, so Dr. Koka, what were you doing? You said you had an interview?
No, I was talking about the North Carolina bill with some local podcasters in North Carolina.
Okay, so give me I want to get to the skinny. Give me the update.
Right. You know, it was brought to my attention by these folks, I think she broke the story.
Oh, the very cool Jewish lady.
Yeah.
Blonde hair.
I guess so.
Yeah.
Blonde hair, yeah. So the North Carolina House Bill 67 that basically seeks to deal with the shortage of physicians in rural North Carolina by allowing international medical graduates to come to the United States and start practicing without going through a U.S. residency training as is currently the law. Right now, you become a doctor in another place, fine. You got to come here and go through a U.S. residency before becoming a physician. And North Carolina says, hey, we got a shortage. We're going to fix this by just allowing folks to come here and start practicing. They say, well, no, that's not quite accurate. They're not just doing that. We have some stipulations. The stipulations are that, let me go through the stipulations really quickly. Must hold or have held a current active medical license in good standing from a foreign country, completed 130 weeks of medical education at a school listed in the World Dictionary of Medical Schools, demonstrate some competency by passing some international medical licensing exam, have a clean record, no revoked, suspended, or restricted licenses. And when I see that, the first thing I think about is like, we can barely manage to do a good job of enforcing stuff here, right? I mean, famously, all you neurosurgeons know about Dr. Death, right? Who went through a U.S. medical school, U.S. neurosurgery residency, came out having no idea what he's doing, and only after a significant number of patients were maimed and died, the colleagues report him, right? The medical boards weren't doing jack squat. Last week, a nurse was found again by a colleague, not by the nursing boards, who didn't actually have a nursing license but was practicing. And so, the idea that North Carolina is going to be keeping track of who is in good standing in Rawalpindi, Pakistan, is somewhat crazy.
All right. Hey, let's get everybody's reactions. Yeah, Dr. DeGiorgio, what do you think about this? What's going on?
Yeah, I'm a little down on it. I think it mostly because it creates an uneven regulatory landscape, right? So if you are a U.S. trained physician, you got to go through residency, you got to get your board certification and all that. But if you're not, now you can kind of take this shortcut. So I guess the big question is, if you are considering you want to go practice in rural North Carolina, could you just go to a Caribbean school, graduate, and then come out and hang up a shingle, having not gone through the residency process? So in a way, I don't like it because it creates this dichotomy that it's actually harder now for the U.S. physicians. But of course, the Milton Friedman in me says less regulation is good. And there's an interesting comment on X that I saw saying, the hospitals really, they fear the reputational effects and won't go out hiring a bunch of doctors who are not trained. Yeah, I know, Anish. I'm skeptical of that as well. But I think there is something to be said for reputational effects. And that's sort of the argument Friedman makes, right, and Hayek, when they talk about decreasing certification and professional regulation for people to enter the workforce, is that there are a lot of reputational effects that will influence people and make it so that there's not just some untrained nobody coming out and hanging up a shingle, that old Far Side cartoon, Frank's Neurosurgery, where the guy's just sitting outside smoking a cigarette, hoping people will come by for a craniotomy.
I'd be supportive of a landscape which had less licensure. I think COVID has taught us that, right? These licensing
I agree.
boards licensing exams, medical boards, maintenance certification. I mean, it's just a ridiculous whole bureaucracy that exists to kind of make it harder to practice it, if you will. And there's a bunch of there's a bunch of rent seekers that are kind of making hay while we're trying to jump through these hoops. So I'd support a landscape of less regulation, less licensure, because again, I think folks understanding that there's not some stamp that says, hey, this person is quality. Folks are gonna create their own understanding of who is quality and who's not quality. And guess what? Dan Choi, Sanat Dixit, Anthony Giorgio do not have to worry, right? You guys are going to be busy as heck, even if you don't need neurosurgery, U.S. medical, whatever, to hang a shingle out. So the problem is.
Oh, go ahead.
Sorry, but the problem. So one last thing. But the problem is that here you're actually the government. The government has this stamp that says, hey, you're good enough to practice, and so you just go. You go to Dr. Death. You go to the guy that was practicing in Kenya last week, and now he's in an OR and he's about to operate on it. So that's my problem with it. It's that it's giving this false sense of security, and people should understand that it really is a false sense of security, and you do need to do your own work.
Dr. Dixit, I've missed you. I feel like either I've been gone or you've been gone. So I'm looking forward to your input here. What do you say?
So before I jump into this topic, we'll have this conversation later on. I was at the University of Tennessee when Chris Stuntz was a resident.
Oh.
So I didn't work with him directly, but I was in the Stratos, and that's a conversation for another time. Look, this thing popping up in North Carolina, I kind of not took a victory lap, but I said this was going to happen. But it's been happening for quite some time. And I think maybe this is not the primary intent, but this is the secondary effect of it's going to diminish the value of medical licensure. It's going to commoditize the concept of being a physician, and it's going to suppress wages. I think that's a bonus for the hospitals and the health systems. They said the two things that are going to happen, if they can't find doctors who want to work within the confines of the system they set up, they will train them. They will train them in their residency programs. And usually where they get the residents for those residency programs is international medical graduates. And they're tied and beholden to them, indentured servitude, because of their visa status. But the secondary effect that I fear is it's going to drive down wages further for our brothers and sisters in the primary care space. And I think that's a really, really bad thing. Counterpoint, when I trained in my residency, and I'd love to hear your guys' perspectives if you shared an experience like this. Two of my fellow residents were fully trained neurosurgeons, one from India, one from the UK. And in the mid to late 90s, they decided they wanted to be neurosurgeons in the United States, so they repeated a residency. They were already seasoned neurosurgeons. Both had been in practice for a few years, but they ran the gauntlet again. And, they did what everybody else did, worked 110 hours a week. And part of that was, I won't say it's a rite of passage, But it was just the professional expectation of, if you want this badly enough, these are the hoops and the hurdles you have to jump through. That is a way you sort of vet people. And these guys were spectacular residents, obviously, because they were fully trained neurosurgeons, but they were also great teachers, imparting knowledge to those of us who were doing this for the first time. And both of them, they're still having storied careers. One of them is a full professor and department chairman over here. These are the sorts of people I think they're envisioning they're going to get through these programs. They may get some people like that. I think they're going to get fewer and fewer people like that. The last thing I will say is, I always look at the NHS and how the NHS treated this, and the NHS used the exact same rationale to bring in these international medical graduates. It didn't take any distress off the system. Access was still an issue, cost was still an issue, but guess what happened to wages? It's a little bit of a different framework because it's single payer, and they're a public good. Physician compensation for because of these international medical graduates actually dropped precipitously. Over the past 20 years, it's gone down between 20 and 35%, depending on which numbers you want to quote. That's what I'm worried about. It's going to continue to devalue the concept of having medical licensure in the United States.
Dr. Choi, you're waiting in anticipation. I want to hear what you have to say. Oh, you are on mute, by the way.
Sorry, appreciate that. No, great points for everyone. I think that, I'm analyzing this, and if you look at the way this law is written, there's some clues here to really determine, right? Like, is this, who wrote the bill? Where did it originate? And why did it get written? The typical reason that whenever any kind of law like this passes, which in our experience from advocacy standpoint, we see this a lot in advanced practitioners, right? Mid-level scope expansion. When you have physician assistants and nurse practitioners, they want to expand their scope typically to do the same things that physicians do. And they want to perform procedures, or they want to do primary care and be independent practitioners. And we see the same exact arguments being made for NP and PA scope expansion, which is, look, there's a big physician shortage in the rural areas, and now the mid-levels are going to meet that demand. And so that's the reason being given here, right? And but really, if you look at kind of the nuances of how this bill was written, it's a temporary supervised license, and it can only be issued, the license can only be issued if there's to a specific rural hospital or practice that hires them, right? So it's tied to employment. And so this is an employer-driven bill, if you really think about it, right? Someone who is having a hard time finding physicians to staff their hospitals, it drove this bill, went to the legislature and spoke to them. And this is not a bill that physicians would have written, 100%, because there is not a single bill that I know about in the United States that allows any physician, even a foreign trained or IMG, we call them international medical graduate, which I have a lot of IMG colleagues that I work with who are phenomenal. Typically, they are the best in the class of wherever they came from, whichever country that they came from, because the hurdles to go through the IMG pathway in America is insane. It's not something I would ever sign up for. Typically, you have to be the top of your class of wherever you came from, go through proper testing. Then you have to take the USMLE here, step 1, step 2, and step 3. And all of us on this call who are physicians took step 1, step 2, step 3. And that was some of the most tortuous 18 months of our lives, preparing and being nervous and studying our butts off to make sure we were adequately prepared. And these physicians typically going the IMG route take that USMLE. The USMLE is nowhere to be found on this law, which is mind-blowing to me, that they're just bypassing that. And the law states that they have had 130 weeks of medical education from their own countries, med school, which there's no way to vet if you came from any of these countries, like what the quality of that education is. Here in America, we have ACGME, we have accreditations that look at these medical schools, and the medical education here in America, we're talking about the brightest and the best students in America that are going through this pathway to become trained and licensed physicians here. And you and I, we all know the U.S., graduated medical doctors, there's a certain level of education and training that goes behind it, 10,000 hours of residency. And the challenge we've always given the nurse practitioners and the physician assistants is, hey, if you want to practice independently here in America and maintain that quality of care, why don't you also take the same USMLE? Why don't you pass step 1, step 2, step 3? You know what? The nurse practitioners, I think, actually tried doing that, or it was the CRNAs who tried to do that. And after a while, they said, we can't do it. And so they gave up that pathway. That was one pathway that was explored. And the fact that we're just bypassing that and giving these physicians a ticket into practicing in America, it reminds me of what's happening in tech, with the tech jobs, where these computer science graduates right now, there's a lot of articles out on this where they're graduating from Harvard, Stanford. They can't find jobs here because these tech companies are going and poaching and giving pathways to these jobs that should be American trained and American educated tech workers should have those jobs. Same is happening here with physicians. And what's going to happen here, the effect and the actual repercussions are much more significant than tech. We have patients, right? This is quality of care, is a quality of care issue, and patients are going to suffer for this. So I'm strongly opposed to this.
Did anyone read anything about malpractice insurance? I mean, I own an insurance company, a few of them. And if I had to issue, right, if we had to underwrite malpractice on this, it'd be very hard to do. Like, how would you do it? None of the normal licensure, as all of you have pointed out, is being followed.
I know how they're going to do it. It's going to be tied to a deal. Right now, I shop around for medical malpractice for my 5 doctors.
Do you ask me to help you? No, I'm just kidding.
Yeah. I have a long-standing broker, but look, the hospitals, I know how they work. They are doing bulk purchasing, just like GPOs, and they're going to go to all the insurance carriers and be like, hey, I need these doctors to be insured. And yes, they may be at a higher risk pool, but if you don't underwrite them, well, we're going to take our business to the other malpractice carrier in this.
Yeah, but that's not how it works.
You don't think so?
Well, it works that way for you because you're 5 doctors, but it doesn't work that way for Duke Health or Advent or Atrium. They're like me. They have their own insurance company that they own, and they underwrite all the risk themselves. But you still have to pay the premiums. Like, the money has to come from somewhere. And so, look, we'll just pick on Atrium. If you're Atrium and you guys are the board members with me, and we say, okay, well, we need, make up a number, 500 more physicians or 1,000 more physicians. How are we going to underwrite that risk? This is why insurance business, we call it risk transfer. Who are we going to transfer the risk of them screwing up? Because we know it's going to happen, because we don't know where they came from. We don't know who they are. You just said that. You said they've not gone through anything. So who's going to take that risk from us?
Remember,
Go ahead, please.
Sorry, I wonder if there's this general idea that physicians are cogs. So I don't think they understand this. I don't know that they understand that there may be high risk. They just see them as like a widget, right? This happens all of the time with upper management, with C-suite. C-suite, like, I mean, so many programs, like amazing programs with these amazing physicians. I remember being at a health system that I trained at, and there was this amazing cardiology program, amazing heart failure program, and there was some stupid issue in terms of administrative stuff, and the entire group just said, "Look, we're going to leave if you don't play ball." And it wasn't an unreasonable request. And the C-suite did not care. Said, "Okay, go ahead. We don't care. We'll find somebody else to replace you." There's this idea that we are commodities, that we can just be replaced one for one. So I don't know if that's what may be operative in terms of them just not understanding that. And at the end of the day, look, you have these like CEOs that are making, whatever they're making, that's fine. But what happens is that whatever bad decisions they make, whatever like $250 million stupid EMR that they bring in that like sinks their system, in 5 years they're gone to some other health system talking about some BS vertically integrated network and blah blah, all the jargon and wheel and spoke and hub and spoke, and it's just ridiculous. But the one thing I just wanted to make the point about, I don't like the wage suppression argument that much, because I listened to the Teamsters Union boss on the Free Press, and man, it was so annoying to listen to him talk to Barry Weiss on the Free Press about how his entire thing, it just comes off as this entitled guy representing his group of folks and the best thing, like, society needs to be organized to keep your wages up. It's like, no, that's not what society is organized. Society is not organized to pay you the maximum amount of money you can extract from the system. So what society's organized to do is extract the most value from it. And so the question is, what's the service? What's the value proposition you're giving? I'm biased. I tend to believe that there's a relatively few amongst us who can perform at a high level, which means that there will automatically be high demand, and there'll be a demand supply mismatch, which allows for high wages for physicians. But I'm not super excited about forwarding that as the hypothesis as that, look, we need to make sure we keep wages up for physicians. So I'm curious. Does that make sense?
Yeah, so I'm gonna not so much push back on that, but give some context. My concern with that is at some point in time, if you have party A that's willing to do the job for $250K, that they can import party B who's tied to you by visa status will do the job for $175,000. Suddenly that becomes the price point to do that job. And party A, who was educated in the United States, will say, I'm going to find something else to do. I don't think the primary goal is wage suppression. I think that's a intended/unintended consequence that we're going to see down the line. The context I'll give you around this is Brett Weinstein. He had a great tweet about 6 months ago talking about this. He's talking about why aren't the best and brightest going into the STEM fields, the hardcore grind STEM fields? Why aren't they going into the sciences? Why do they want to go into administration and business and all these other managerial type roles? It says because the opportunities are greater and the investment is lower. The people who tend to move into those disciplines are immigrants, international medical graduates who that's their path up. But he talked about an anecdote he had with a guy who ran a research lab, and the PhD who had his battalion of postdocs, the postdocs were all Asians, and he referred to them using the term STEM coolies. And I'm like, that right there is what you're getting with this bill. You're getting STEM coolies. Not so much from the standpoint they look down on these people, but we know these people will work for less. And if they're going to work for less, why would somebody who's graduated from an osteopathic or allopathic U.S. medical school want to bother to perform in the same capacity? 40% of the 40% of the house staff, junior and senior house staff in the UK is international medical graduates. Why is that? Because a certain portion of the native-born Brightons just said, yeah, we'd rather be in marketing or do something else. So I think that's kind of an after effect, but it's still going to have a consequence, and it's going to affect our colleagues who are in some of these specialties.
I'm like wanting to hear from Dr. DeGiorgio here.
Well,
What do you have to say? He's getting all wound up like a batter. I was like, holy shit.
Just out here in the People's Republic of Gavin Newsom, we've passed a law where nurse practitioners do have independent practice rights. And in addition to that, physicians, in most of the country, if you do an internship, you can actually go practice independently, even without finishing your residency, right? You can become, quote unquote, general practitioner. They took that away in California. So first year medical residents cannot practice independently, but nurse practitioners can. And what they found was all the nurse practitioners, are they going out into the Central Valley and Bakersfield and Fresno? No, they're going to derm practices and doing Botox injections and things like that. So people will still follow the money, and it really doesn't end up improving access to healthcare at all.
I think we just have to be what I would suggest focusing on is reducing the barriers and the hurdles to becoming a physician in the United States, right? Look, the country, you don't have to make an argument that the country has a certain duty towards its citizens, right? So you're going to accomplish the same thing, Sanat, by simply lowering the regulatory barriers, pushing for lowering regulatory barriers to becoming a physician here. Meaning, do you really need to do 13 years? Sorry, 13. So what you guys do 16 years, right? 13 to 16 years in cardiology to after high school to do what a lot of folks are doing. Do we need to have and accumulate that kind of debt here? And it is perfectly 100% reasonable for the United States to prioritize its citizens on that front, right? In terms of, but it's silly to create a easier pathway for non-citizens versus U.S. citizens. So I think if we push on that end rather than, because what I think we have to be really sensitive to is this idea that we do not we do not want to come off as yet another cartel attempting to keep prices high because that just is not going to fly.
Right.
We're a minority of people, and we're going to come off like that Teamsters boss. So look, yeah. So I think that, and the argument is it's not a hard argument to make. I mean, look, there are only so many spine procedures that happen in the United States per year. There can only be so much training that happens in the United States per year of neurosurgery residents. So it's not like you're gonna anyway. So I think there's some natural things here that are always going to keep, if we do it right, are going to keep what you're talking about, like the NPs, like the NPs that are training. I did an interview of an NP that literally went to an online school, did no nurse bedside stuff. I mean, it's insane. It's basically an online NP diploma mill, right? The entire reason she did that was because she could do aesthetics, and all she does is aesthetics. Yep. So the idea that like these folks are going to go into rural. So my point is, regardless of what you do, if you set things up right, you're still going to have an ample demand for the right folks, and you're going to have high wages. But we just have to be careful. I think about
a question for you guys is you Dr. Dixon, you made the comment of 250 versus 175, right? And I think there's a good number of people in the United States that can just pay whatever they want. So Dr. Choi has talked about IDR a bunch. Do you think that someone who says, I can pay whatever I want and have surgery for whoever I want, is going to choose someone that they can't communicate with, they can't understand, that doesn't have the right education, or that doesn't appear to be the expert that someone else might be, right? Because I can't make certain clinical assumptions, but it appears to me like I would go looking for value, right? And that's really hard to do in healthcare. So like, Dr. Choi, is it your idea that someone would choose a new immigrant from XYZ over someone like yourself or the rest of the team?
When I think about this, I'm in a specific specialty. I do elective spine surgery, and patients are shopping around and they're informed, right? But I would argue that probably 98% of critical medical care is not elective spine surgery. It's in the primary care setting, it's in the emergency rooms, it's inpatient setting, where patients are thrown into a situation typically not of their own choosing and needing medical care. And this goes to this whole problem is that everyone wants to solve a healthcare worker shortage. And yes, wage suppression is I don't really care. Like, it's not an argument or not an argument. It's right now, if you really think about it, who's making this decision, right? It goes back to me, who put the bill up? It's the C-suites, right? The C-suites wanted this because they have shortages. They have regulatory requirements. They've got to have staffing levels at a certain point. They're the ERs that don't have enough emergency room doctors. They're like, we got to find the doctors. But also, probably that's part of it. But part of it is also that the C-suite sees physicians as the most expensive line item. And when you're talking about optimizing your bonus and optimizing the balance sheet, physicians are a very expensive line item. And this is one way to decrease the impact of that line item and get cheaper labor at the end of the day. And on the flip side of this is that when you think about your family member or yourself ever needing medical care, I've needed a doctor, once in a while. My family's needed, I can think of one very critical event in my parents where, it was like all hands on deck. We had to rush. My mom had a stroke. We were rushing in and I was just praying. I was like, dear God, please let the neurosurgeon who's seeing my mom be board certified, trained, be ethical, be moral, and all the things that, we screen for at medical schools. I'm on an admissions committee here at a medical school locally, and we have rubrics and we are grading every facet of this student that comes in. They're usually the best in their class, but not just that. You're looking at the moral compass. You're looking at volunteer work. You're looking at does this person, are they a good human being? We're vetting all these things to let them have the privilege of entering this profession that is a sacred profession. And that's how physicians treat this profession. When we let people in, it is such a big deal. And when we get in, oh my God, You remember your first day as an intern holding that pager. You remember your first day as an attending, seeing your first patient, and that responsibility and all the training that was poured into you to make sure that you do your job right and you don't F it up. Okay. That's the one thing we're worried about, that we're going to hurt a patient. The medical profession would never write a law that is written like this. We're just bypassing all the things that we hold sacred in this profession and saying, you know what, fuck it. Like, we just need cheap labor. Let's bring them in. Okay. That is so antithetical to what the medical profession stands for and what this podcast is trying to remind everyone. And I think this is so critical, is that it is so important for us not to lose sight of what the medical profession stands for and the good old days. We always look at the good old days of this profession like, oh my God, those are never coming back. But this is a profession. If you lose that, we lose the profession. We lose everything. And we really have to remind people why we went into this profession and all these infrastructure things that have protected the profession. And it's unbelievable to me that this law just passed without any resistance from the North Carolina medical side. I don't think they even got invited to comment on this, is my suspicion. They didn't get any input. And and I want to make one last point here, is that this is one of the things that are going to corrupt, and it is going to bring medical care quality down to levels that in this country that we haven't seen before, okay? And I'm predicting this. You know why? Because you're not allowing physicians who understand healthcare, who understand what is good for the patient, a seat at the table to render their opinion and put up safeguards. Like this bill, if you look at this, after 4 years, they get a full unrestricted license and they can practice anywhere in the state. They can actually go now through this interstate compact to another state. After you come in and you do your 4 years, the rural area, you're out of there. You're going to the city, you're going to New York City, you're going wherever you can use your license in America. That's what's going to happen. And physicians, again, we would have never written this. And this is what happens when you don't have physicians at the table in New York State, when Andrew Cuomo forced down nursing homes to take in COVID patients, which was the worst. I had my mom in a nursing home. I was going crazy on X. You go to my 2020 posts, yep. I was going berserk about Governor Cuomo letting patients go right from the hospital untested into nursing homes because the hospitals needed to clean out their beds. I knew where that was coming from because they did not ask the medical society about whether this was a good idea. Every one of us was screaming, this is stupid. This is the most ridiculous thing I've ever heard, to let this contagious patient go into a nursing home, which is like wild, and let the virus spread like wildfire. And that's one of the things that brought him down ultimately, right? But he did not let us weigh in. And you're going to see decisions like this being made across the country. And then 10 years later, 5 years later, you're going to see the impact of it. And it's not going to be good for patients.
Dr. DeGiorgio. Oh, just 1 second. I'm going to ask you a question too. I've been thinking, and this is really for you and Dr. Dixit, is generally businesses do what's in their best interest. What's in their best interest is not hiring people who can't do their job, right? So I'm interested in the feedback. Like, it doesn't feel rational. If I was an executive, I could never be an executive at a health system. They hate me too much. But if I was, right, I wouldn't write a bill like this because there's too much risk. And I'm like the all-time pessimist. I'm the all-time optimist. But there's too much risk. If you hurt a patient, this is bad. So is there any logic here? Is there any rational thinking here? Or is this just pure unadulterated greed or somewhere in between? Because I can't understand it.
I mean, it's a lot of this gets to the point of what is modern hospitalist or a modern doctor, right? They're not, I mean, the hospitalists, God, I love them, but they have very little clinical decision-making they do, right? They consult a bunch of people, and their job is to check boxes in the EHR, get discharges out by noon, make sure that the 12-point review system satisfies whatever JCO requirement the hospital made up for that day, right? They're just there to be glued to a computer and to fill as a warm body. Again, I love my hospitalist colleagues. I wish that their quality of life was a lot better. I wish that primary care was a lot better. But I think what they're looking to do is just import some people who can be compliant, who will check all the boxes in the EHR and make sure that the discharges are all done by noon, the coding queries are answered, and that they've upcoded as many visits as they can to meet their maximum DRG. That's what they need. And to Anisha's point of the workforce not being able to meet workforce needs. Again, on the back end, we keep coming back to this, is because that is what modern medicine has become. People are retiring. The American doctors are looking for the quickest exit. They don't want to keep practicing anymore. And you're actually losing the most valuable doctors when you do that, right? You can pump out a bunch of new grads and get a bunch of people straight out of residency or foreign medical grads, and you're losing all the seasoned doctors who actually make the good decisions, who don't cost a lot of money, who are thoughtful, compassionate thinkers. They're all leaving because the practice of medicine is not what it used to be. And frankly, if you're talking about wage suppression, we can make good money elsewhere. There's a lot of things, especially those of us that are subspecialized, that we could do outside of clinical medicine and still maintain a pretty high salary. And so if the practice of medicine, it becomes worse and worse, let's get after, jump ship, get somewhere else and keep up that lifestyle without actually being tied to, clicking through an EHR all day.
Dr. Dixon, you are one of the guys that I know or have known for a long time that is also a business professional. How much sense does this make to you when you put on your business strategy brain? Like, what does this say? I don't understand.
Well, I just want to piggyback on something Dan said. The one thing he didn't mention about neurosurgery is great personality. So you had your bases covered there, because you're not going to find them. So I did a little bit of digging on this. North Carolina is not the only state that has this sort of quasi-parity law. There are about 19 states that have some sort of parity law for IMGs. And there are 7 states that are looking to pass something very, very similar. That was surprising. What was even more surprising to me is most of the places that are passing these parity laws are red states. So I was like, I think road to hell being paved with good intentions. I think there are some good intentions over here. They're trying to solve a problem. The red flag for most of us is how they're going about doing it for a number of the reasons that we have described. I'm going to push back on this concept here a little bit. We're likening a lot of the people who are going to be doing this to the Sikh guy who basically did the illegal U-turn in Florida. He didn't have a commercial driver's license. He came into the country, and like that's the nightmare scenario that we're portraying over here. Yes, that scenario could probably happen in this context. I don't think that's most of what you're going to see. Most of what you're going to see is like good, earnest people who just want to practice medicine over here. But I think to Anthony's point, I think he's spot on. They are there to be that organizational resource, that widget, because somebody who graduated from an allopathic or osteopathic American medical school is not going to fill in that job. The other thing, Dutch, you're absolutely right. Most informed consumers are going to say, who is the best person? But you notice where they're putting these people. They're going to put these people in places where they can't get anybody. These people are not going to have a choice. And if you look at how the hospitals market, the hospitals don't market Dan. They don't market Anish. They don't market me. They don't market Anthony. They market the service line. The service line is this anonymized entity. We are Borg. Resistance is futile sort of thing. I think putting on the business hat, it's just like, well, great. We can import a workforce. They'll work for a little bit less than the typical people we have. We can basically make them order tests and we can have them be compliant. And basically we have them under our thumbs for a little bit. And yeah, we can pay them maybe 25% less than the market rate. My concern is not so much our salaries won't stay artificially high. It's just why would you, if you're a U.S. citizen, want to go to medical school? If you're going to have this 2-tiered system and you're going to have this other tier where the business people are basically trying to diminish the value of the medical license you spent $250,000 in 8 years of your life earning. And I'm going to throw a real wild card into this thing right now is in the next 5 years, just wait, there's going to be lobbying to give some sort of licensure parity to an AI. The question I was going to ask here is, Dutch, how much do you think the hospital spent to lobby to get this bill across the finish line? That's what I'm interested in.
Oh, I love this question. So in the state of North Carolina, last year, 2024, we put in almost $3 million to lobby certificate of need. And we got nowhere. So what do you think? But what do you think Advent, Atrium,
ECU is the primary beneficiary because they have most of the rural footprint in North Carolina.
The local health systems have such a huge imprint on the local economy. It is very, very hard to be a politician to go against that because you are literally.
Oh, if you're at Pitt County at ECU, you're not going against anybody. They're the biggest employer in Eastern Carolina. Like, what are you going to do?
To Dan's Right. So to Dan's
Yeah.
point, I mean, they should rename it the indentured serf bill. But to Dan's point, yeah, this is 100% something that is for the employed health systems, because what the health systems want is employed cogs. They don't want a bunch of independent physicians. And so, but it's so crazy to see. And it's a great example of how dominant the interests of health systems are on both parties, Democrats and Republicans. As you pointed out, this is in North Carolina. This was forwarded and passed by Republican legislators. So instead, the Republican legislators, instead of, and these are physicians, instead of going after the pain points, and this is what we needed to go after, the pain points of like, why is it there's this physician shortage? It's the regulatory burdens. It's the finger on the scale that benefits the health systems. It's not allowing an ecosystem that would allow DPC type contracts, DPC type memberships to kind of exist, which would solve that shortage, right? It would get to that root cause. They have this Band-Aid model that is there to serve the health systems, but it's just so completely brainless on so many fronts, and it shows the kind of the long steep hill that we have to climb. But it's doable.
The question that I still have for you guys is, I don't understand the risk you're taking. Right? If everything I've just heard from the four of you this evening is there is diminished skill, right? If there's diminished skill, that means the 11.4 million people in the United States who go from an ER entrance into an ICU, right? There's 11.4 million people that happens to every year into an ICU. That means those people are in real trouble.
But Sanat's right. Sanat's right in terms of your response to that. Like, we're talking about the edge cases where, like, the one in 50 or something that are going to get in, that are going to be some egregious type of, thing like CDL that doesn't have a license or something that, makes a huge.
You think the majority of them will be fine?
Well, for what the current system demands, right? I mean, we're not selecting for like the world's greatest cardiothoracic surgeon to be coming in. I mean, what the regional health systems are looking for are bodies to do direct primary care, be hospitalists, be primary care physicians, to be these kind of lost leaders, right? And they're looking to do that at a lower cost, right? And then they don't have folks in the domestic surgery that want the job of like clicking EHRs and checking quality metrics and sitting in stupid committees and all that stuff. So I think they're not, in response to your touch, they're not hunting for, the Anthony DeGiorgios, Dan Choi's, and Sanat Dixits necessarily. That's not what, this regional health system is looking for. They're not looking for some hotshot neurosurgeon to come in and like create a neurosurgery program. They're looking for basic bodies to do basic things, which they think they're going to be able to get away with, which Sanat is right. They're going to be able to get away with it most of the time.
And even if there is errors made, they've probably underwritten this. They've probably had
They're not
your
not-
question.
yeah.
Maybe, but what they probably did is entered some error rate, right? That has led to some complication or misdiagnoses. And what they've done is maybe they don't have models for that. Maybe they're not modeling for that. But there's two components. I believe that they probably modeled for it somehow and said, you know what, the amount of revenue that we're generating by having cheaper labor is worth the underwriting risk of whatever increased complication may happen from this. They may have factored that in. And secondly, remember, these health systems have amazing, very, very coordinated and very complex PR, okay? And we saw this in COVID here in New York State, where any kind of negative press or any type of situation that would have made the hospital system look bad, oh man, their PR teams were on it. Releasing positive press releases, changing the messaging. So even if there is some kind of risk, and Dr. Dixit made a great point about how it's not about featuring the physicians. They are not trying to sell patients on their physicians. They are always trying to brand the health system. And right, that is a fundamental
for sure.
complete shift in the profession of medicine too. You can't actually go on these websites for health systems and find their star neurosurgeon or their star cardiothoracic surgeon, or even though they recruited these specialists, typically saying, oh, if you come here, we're going to build out this amazing program. We're going to make sure you're the head of this, and we're going to feature you. That's not what happens. When you actually go and look at these websites, maybe they'll write a feature article and whatnot, but really they want all the physicians to fall in line under one brand so that they can evenly distribute these patients that come through the door to any physician that has an open schedule at the end of the day. That's what's happening. And so these PR firms combined with, their marketing, I think they've made this calculation. It's not going to really hurt them that much at the end of the day.
And everything they do is protocolized, right? It's just clicking boxes in the EHR. Sepsis alert. Okay, I got to order XYZ. Chest pain, I call cardiology. Brain bleed, I call neurosurgery. I mean, it's all so protocolized that, again, it's just somebody that they just need to fill the spot and click the things and make sure the coding queries are answered.
They're going to be malleable. So I brought the term STEM coolie. Anish knows what I'm referring to. I don't know if you guys know what I'm referring to. You guys know what a coolie is? A coolie is a porter in India. When you got off the train, you say, "Are coolie, yahan pe aao. Come here." The coolie is the guy that stacked your luggage up and just did whatever you wanted. They were just a workhorse. And Brett Weinstein was taken aback by that term because he knew exactly what that meant. And the guy didn't mean it in a derogatory fashion. He just meant, these are chits. These are widgets.
All right, look, I think we've had a really great talk about this. Does anyone have another comment? Otherwise, I'm going to move on because I have questions about other topics. All right, since Dr. Koch is here, I want to talk about your favorite bro doctor who's back. I want to hear, man, I'm so stoked about this deal. All right, talk to us about Vinay Prasad, and he's back. What happened?
Yeah.
What's going on?
So crazy. The crazy thing that happened for folks that haven't watched the last episode or haven't been following is that Prasad comes in. He's doing a ton of work. He goes up against a gene therapy company called Sarepta, which kind of got an approval for its gene therapy based on kind of shoddy data in 2023 and 2024. There's 3 deaths that are now reported in teenagers, and Prasad's CBER, the FDA division that he leads, starts to pull the approval starts to make moves to suggest that Sarepta's gene therapy has not long for this world in terms of being on the market. And the next week, incredibly enough, Laura Loomer has this like crazy story, which she clearly didn't write all of it, that implicates Prasad as being some left-wing loony that's derailing Trump's agenda. And then, amazingly enough, within a week, Prasad is like gone. He's gone. He's been, called from the White House. Prasad's gone. And we were all stunned. It's like, oh my God. We didn't quite realize the hold that biotech via lobbies in DC and all these backroom dealings had on the FDA that's supposed to regulate them, right? And so, this depressing podcast that we did the last time, which was like, oh my God, I can't believe like this is happening. And then there was a campaign, Kevin Bass, former med student, Ned Ryan, a bunch of folks kind of had an online campaign to try to get to folks to understand that this was probably a takeout, like pharma or some biotech interest literally took out the FDA regulator that was standing in the way of some shoddy science, and somehow it made it into the right ears. And boom, Prasad is, we heard, a few weeks ago that a week ago or so, that Prasad is coming back. And then today, just like an hour ago, I see a story in the Free Press about Laura Loomer, who's this right-wing influencer, saying that the White House is now getting sick of Laura Loomer's kind of diatribes, because some of those diatribes may be planted by some lobbying arm or the other. So there's this question swirling about where Loomer is getting her information, which then results in X, Y, and Z happening. And so it's a fascinating. So anyway, so Prasad is back. We don't know in what form he's back. Been relatively quiet since he's come back. So we'll see.
Isn't it amazing though? Like
States.
You hear about people like the Laura Loomers of the world. I mean, they're literally paid to plant stories. They built up an amazing following by doing whatever they do, like maybe telling the truth, maybe uncovering things and hustling like a true journalist. And then, of course, they start getting paid. It's insane how many influencers on X and other locations or LinkedIn are that way. Getting paid a lot of money.
Yeah.
Yep.
Fascinating story.
Okay, the 3 of you look bored. I'm like, what? They're like, this story again. And I'm like so excited about it. I'm like, he's back. Let's go. I got my Eminem. I think it was Eminem. Anyways, Dr. DeGiorgio, you had an amazing post this week. I know
Just one.
I know you guys all did. Hold on. I got to finish complimenting everyone to make sure no one has their feelings hurt. Just kidding. I said something about doctors the other day and on LinkedIn, and all of these people were like, nurses save lives too. Non-surgeons save lives too. And I was like, are you guys all 5? If I compliment somebody, and they are all 5, by the way. So I love this post about catastrophic insurance. Why don't you talk about it a little bit? Because I was out of my mind. I was like, yes, mean reversion, more of it. Like, talk about needing and mean. I was just out of my mind. I was loving it.
Well, this guy was trying to convince me that everything needs to go through insurance because the average American spends something like $14,000 a year on healthcare. And yes, if you look at the mean, there are some very high expensive events that drive up the mean to 14,000, but the median American spends about $500 a year on healthcare expenses. So, and I think Dutch, you even brought up the point, what 90% of people don't even meet their deductible.
Yep.
So you essentially have a free market, and that $500 a year, that is less than we spend on car maintenance. That's less than the median American spends on coffee. That's less than the median American spends on pet services, on streaming subscriptions, and on food delivery. So that's not a big amount of money. And so if we had more of a catastrophic plan, that would just sort of cement this idea that most healthcare transactions, if you look at the total number of transactions, most healthcare transactions are private goods, and they've been handled in a free market, cash pay type way. And you have catastrophic insurance for that 10% who meet their deductible, end up on Sanat's operating table, or end up with cancer, or end up with some high cost event. That's when your insurance kicks in to prevent the catastrophic financial loss. But for most of us, and like I think, Dutch, you even bring up this stat repeatedly as well, is the number of healthcare transactions that fall into something that is shoppable and elective is the vast majority of them. And if we took all of that out of this third payer insurance model, the prices would go down, the quality would go up, and people would just accept the fact that, maybe I should shop around for my primary care provider and not expect my insurance company to pay for it.
Does someone here have an understanding? I don't, which is why I'm asking, of why we don't have catastrophic plans anymore. What was the change?
There's the ACA. They're
right.
prohibited under the Affordable Care Act.
Essential health benefits.
Yes, the essential health benefits.
I remember that process. I was pretty old by then. But I remember thinking, like, when I was in college, my father got me a catastrophic plan. It was a $10,000 deductible plan. But it was essentially like, hey, son, if you get in a car accident and you're toast, like, we could pay for everything because we'll come up with $10,000 in that case. Everything else you have to shop for. So there's a couple issues. Go ahead.
Sorry, the American consumer was judged to be too stupid to be able to buy insurance and to select through different plans. And so, they came up with essential health benefits to say that, okay, if you want to be an insurance broker, if you want to be an insurance company that provides health insurance, you must provide essential health benefits. And the crazy thing is, okay, fine, what are essential health benefits? But because, these are like moral busybodies, my favorite phrase, the essential health benefits had to be everything. You had to provide oral contraceptive must be covered, because if you don't provide oral contraceptives, I mean, there'll be disaster. I mean, if you don't provide oral contraceptive,
they sued the Little Sisters of the Poor.
Yep. Oh, that's right.
Yep. Because that was an insurance plan that didn't cover oral contraceptives. So, but nope. I'm telling you, this moral do-gooders that want everyone to share their values. It's just that's what breaks everything.
Okay, so here's then my follow-up question. One of the things that I think would help our argument, because I think we're all on the same page, right? I think catastrophic insurance is way better. Certainly for people that have chronic conditions, right? As an employer of a lot of people, I would be more than happy to pay for catastrophic insurance for everyone who had a chronic condition, including one of my best friends who works for me. And the trouble is, where does someone go? Where does a patient go? Right. And let's just assume, like, average income, good person, like decently smart, normal, kind of, not someone completely down in the dumps. Right. If they want to shop for a lab test, or they want to shop for a PT visit, or they want to shop for a colonoscopy or upper endoscopy, like, why do physician practices make it so hard to find that? If I need, a CAT scan, like, why is it so hard to find these prices? Because, I mean, like, I know where to go because that's our business. But the average New Yorker, certainly the average person in Philadelphia, he has no idea what to do. How do we solve for that problem to strengthen our argument?
So, when you talked about this essential health benefits thing, I actually just asked ChatGPT just now, about catastrophic health insurance. And it's
Dr.
actually lighting, like a big light bulb just went off, which is, again, Affordable Care Act, which, again, President Obama actually tweeted about the ACA this past week. I reposted him with the exact same post that I wrote back in March. Exact same. I just wrote the word again in front of it. I said, I regret, supporting President Obama and passing the ACA. And then hilariously, Elon Musk somehow saw my tweet again and wrote, wow. And that tweet didn't get 43 million views, but it got 34 million views. But it all comes back down to the ACA. If you think about this legislation, just like the North Carolina bill, who wrote it, right? If you think about essential health benefits, it basically, the ACA is what got rid of low premium, high deductible policies. And I got another 500 replies to this post that I wrote. And I had about 10 to 12 people talking about how they used to have these catastrophic health insurance plans. And I actually didn't know what they were talking about, but now I know, which is it didn't cover preventative care, like going to your primary care doctor, getting x-rays, getting MRIs, the basic stuff, right? And it only covered if you got cancer or something crazy and you needed emergent surgery. That's what it would cost. But basically, the Affordable Care Act abolished those plans, which is, to me, insane. It's blowing my mind because it got rid of it basically was a market distorter, a ridiculous market distorter, because now it's picking winners and losers again, which is any plan, because there would be a market for this. And Dutch, this comes back to your question of why aren't people listing pricing? Well, this is one of the factors. If people are not going to be able to use their insurance to pick pricing, then why would anyone post their prices? Because no one's shopping. There's no market for it at the end of the day. You need to have a market. What the major health insurers did through the ACA is basically eliminate the motivation for anyone to shop around and this is market capture, right? It's classic regulatory capture, which is by enforcing this essential health benefits that every plan has to have. They are basically capturing all those healthy patients, right? That's all they need. They only need the preventative care. They don't need the catastrophic chronic illness. They don't need the dialysis care. And so you've gotten rid of this entire market. The health insurers got rid of this plan that was low margin for them, and they basically forced the American population to only have the choice of having this product. I bet
it was a chess move for sure.
It was, and they won. You've got to undo that. That's the only way you're going to create a market.
Yeah, it's the Toyota Hilux of insurance regulation, right? You can't get that cheap Toyota Hilux truck in the U.S. because it doesn't meet the regulatory standards. There's a really cool post going around on X as well, where this lady talks about how she took her kid in for their wellness visit, and she asked a question, and because she asked an additional question on top of the wellness visit, she got this huge bill. And that goes back to this essential health benefit, is that the wellness visit had to be covered. It has to be zero cost sharing for it, and it got its own CPT code. And so what happens when that lady asked an additional question, it took it from a wellness visit to a 15-minute 992, what was it, 213 office visit. And so she got a bill for that office visit on top of the wellness visit. That lady had no idea, and nor should she know that that is what happens, because nobody posts that as their price, because people are expecting that, hey, insurance, my wellness visit is a essential health benefit. I have to have insurance cover it. Why shouldn't insurance cover this essential health benefit? Well, that's what happens when you end up with this market distortion, and you end up getting charged this fee for asking a simple question. That would never happen in a real life free market situation.
I think the problem, Dutch, is that the folks that offer cash prices are really out of network with most insurance companies. So if you're in network, right, with a bunch of insurance companies, you accept Medicare, so there's some rate you're getting paid for an echo for that. Then there's a commercial IBC that's paying you some rate. It's like, what number am I supposed to do? So, you kind of, you don't have what's your, so you don't have a price, you don't have a pricing list, because you're also terrified of running afoul of some rule that says that, hey, you're charging something that you shouldn't be charging. So I think a lot of it is like this opacity. Well, one, there's such a high percentage of folks that are in an insurance model, right, that are not in just an HSA, whatever, so that most doctors feel like they have to be accepting insurances. And then once you accept insurances, then it becomes very hard to have, a fee schedule that's reasonable, because your fee schedule is like, basically like 3x Medicare or something like that, right? And it's like, okay, that is not the cash price that you're going to do if you had to set a cash price, which is not 3x Medicare. So then you're in this situation where you have what you would charge for something versus what your fee schedule is, and those two things are different. And then so I think there's this concern. So I think I do think some of it is an education part, meaning I think we should probably be more, at least for speaking for me in private practice, we should just be more transparent, not just do the stupid fee schedule and have our fee schedule and our prices be the same. Yes, that means I may lose out on some third party that pays more than whatever.
Can I offer a middle solution?
Yeah.
So the middle solution is there are, call it 5 large direct-to-employer companies.
Yeah.
Those 5 also include all the religious ministry health plans that people participate in. Those are done via contract. And so that is a step towards transparency. I like to tell the docs that we work with is if one of those 5 approach you, if it's someone outside of that, I wouldn't even bother with them. But like for you, Dr. Coca, like the KISS card is pretty popular in Pennsylvania. I mean, that's where it originated, right? That's a good company for you to contract with because they have employers in and around Philadelphia. And so they deal with whoever the Blue Cross Blue Shield people is that I hate. And I remember what they're called. No, it's not, it's Imperial Industrial. No. Who's the Blue Cross Blue Shield chapter in your part of the woods? Who is it?
I have no idea.
Oh, I'll think of it in a second. Anyways, they have like a favored nations clause and all these employers were afraid and the docs were afraid. Anyways, the point being like, that's a nice middle ground is the direct to employer gets you to the people who are shopping for services or are highly financially incentivized to shop for services. Like they have a no copay, no deductible, no co-insurance, and no pre-authorization program. It's pretty nice. It's a good way to get to piece of that. But I agree with you. I think if I was a practicing physician and I accepted commercial insurance, I don't know how I'd do it. If I had an e-commerce shop, I don't know how I would do it. I'd work with the employers, but I probably wouldn't have an e-commerce shop.
And you couldn't for your Medicare patients. So you end up having a two-tiered system, right? Because it's illegal to offer a cash price for Medicare and Medicaid. And so you have to have this list of cash prices and say, oh, by the way, if you have Medicare, does not apply. I can't even.
How does that work? Because under the NSA, if I get a good faith estimate from you, I'm allowed, no matter if I'm covered or not, to pay cash.
No, you can't. If you have Medicare and you're a Medicare provider, you're enrolled in Medicare, you're not allowed to.
You can't pay cash?
Offer anything under the Medicare fee schedule. Correct. At a cash rate. Yeah, that's
okay.
My basic understanding of it. And so anyone who comes to our practice in Medicare, our whole entire practice is, participates in Medicare. So, we are not allowed to bill at any other fee schedule.
We're gonna have to have a long conversation about in and out of network and how we do that.
But
you might all have to wear masks though and hide.
Medicare sounds like. Say Medicare pays $150. You can have, a fee schedule that says, well, I'm billing $300.
Yeah.
You're just paid, but that has to be the same. And, if it's you get paid, Medicaid pays you whatever they pay you, Medicare pays you whatever they pay you, but your fee schedule is X. So you can.
Right. But you can't, and that's why most DPC doctors drop Medicare because they actually want to offer their services at less than the Medicare rate.
I feel like we've had a good conversation. Everybody's good. We're all happy. I'm really excited about the progress of this podcast. I know I've said it 40 times, but I'm extremely happy with all the work and all the feedback we've gotten. 1,200 downloads in the last 7 days. That's immense. We're in the top 7%. No, it says top, hold on, I'm looking at it right now. Top 6% of all podcasts in the country. Not bad. It's not bad for a bunch of immigrants turned Republicans and conservatives turned, we don't know what will be next week. We'll decide, especially after these Republicans in North Carolina have screwed up everything.
People around San Francisco have been putting stickers on Teslas and lampposts that say kill all Republicans. So for the record, I'm independent right now.
How lovely.
Dude, get a Harris Biden sticker, man. What the heck?
I would. What's wrong with that? Lots of good World War II vets wore the enemy's uniform to save their lives. I'm all for it, bro.
It's-
All right. Well, listen, thank you guys for being a part of our audience tonight. We really appreciate every single person that listens. We want to talk about the things that affect your lives every single day. We want to help you grow your private practice. We want to help you discuss policy issues. Many of you text us quietly by saying, I'm anonymous because I don't want to get in trouble with my health system. We love you and we appreciate you. All right, guys, good night.
Thank you.